Okay, good morning, everybody. I hope everybody's doing okay, and I'm just going to get the presentation pulled up. Is everybody able to hear me okay? Okay, thank you. So I'm so happy to have you all here, and thank you for taking the time to be here. I know I've checked in individually with you all, but I had feedback that a group meeting might be beneficial, and hopefully this gives everybody an opportunity to share and discuss further. And so before we get started, a quick reminder for those who are members, it's membership renewal time. By following the link on the screen, you can find instructions on how to renew your membership. It's easy and quick to do. And then this year, we're also asking members to add a few more pieces, including Wisconsin Cancer Plan priorities, counties you serve, and the populations you serve. If you have any questions, please feel free to send us a message. And then if you're not a member, you can feel free to sign up at any time. And then just a few housekeeping notes. This meeting will be recorded and shared broadly. You might have heard that already. And then please keep yourself on mute unless you're actively speaking. And also feel free to put on your camera when you are speaking if you're comfortable. Also, you can rename yourself if needed, and you can click closed caption to start viewing and any closed captioning if that helps you understand a little better. And then if you're having any difficulties, please reach out in the chat. My colleague Allison Antoine might be able to help. And then just for a short agenda, so 9 to 10 a.m., we're going to have flash talks. This is similar to what we did before. And this is your opportunity to share your successes, barriers, anything that you've been dealing with. And then 10 to 10:25, open discussion. This really can be questions regarding work a site is doing or something you want to learn about more, or just survivorship more generally. This is really your time. So I want this to be useful to you all. And then we're just going to do a brief wrap up. And we may end early, and that's okay. I figured it was better to have a little extra time scheduled rather than less. And then I just have some guiding principles for today's meeting. And so firstly, allow yourself to be a learner. Regardless of your role, your institution, the progress you've made or not made, I hope that we can all learn from one another. We are all here with one goal: to improve cancer survivorship in Wisconsin. Relatedly, everybody's voice and work is valuable. I don't want anybody to come away from this meeting feeling like their work or voice is not important to this discussion. And I really value that all of you are here and participating in this. Allow for and expect different opinions. Everybody has different approaches to cancer survivorship. Respect the confidentiality of what others share. Perhaps somebody shares some barriers they've been facing, and I just want everybody to have an open space to talk about that. Actively listen and ask questions to learn more and understand one another. And expect unfinished business. We're not going to single-handedly solve cancer survivorship in Wisconsin today, but hopefully this forum gives us an opportunity to share and problem solve together in a safe environment. And then before we get started, if there is anything you want to add, please let me know. You can put it in the chat or unmute yourself. And I'll just give you a second. Okay, I'm not seeing anything in the chat, so I'm going to go forward. So firstly, Dr. Cairo from, my slides are going on. I'm not sure what's going on. So firstly, Dr. Cairo from Aurora. I'm going to reshare the PowerPoint because it keeps changing on me. One second. I am just going to reshare the PowerPoint. Give me 1 second. Okay, let's see if this works a little better. So Dr. Cairo from Aurora is unable to attend today due to clinic duties, but sent some information along that I can share. And so Aurora's objective was to develop a web page for cancer survivors that covers a variety of key topics meant to be complementary to in-person clinical care. And then Dr. Cairo shared with me some barriers of staff turnover and IT constraints. However, they did successfully identify and develop content and we're currently waiting to have the survivorship content added to the Aurora Cancer Care webpage, which was just added at end of July. They also now have a dedicated survivorship page and hope to add more content as they are allowed. They hope this is the first step to ultimately developing a more dynamic and interactive survivorship webpage in the future. And then in the future, they're hoping to conduct focus group testing with cancer survivors to receive and incorporate feedback on the webpage and the content that they provided. And then Allison is going to share in the chat just the link, and that's a sample of what they've been working on. So really trying to focus on a comprehensive overview of what cancer survivorship is and how that's impacting people. And so I will have her share that in the chat. And then I think we have Chris from Ascension, Southeast Wisconsin. Are you able to unmute yourself to talk?
Yes, I think, can you hear me?
Yes, I can hear you well. Thank you. And you can just tell me next slide whenever you're ready.
Okay. So this is just all of those that are encompassed, and then Sherry and Deanna are on the call as well with us. You can go ahead and switch slides. There we go. So these are just our objectives as our survivorship program. Enable patients and families, caregivers to maximize their quality of life. So we try to address and manage their physical, emotional, cognitive, sexual, and financial effects of cancer by providing interventions and resources, promoting the healthy lifestyles and reduce risk behaviors, ensuring long-term surveillance and multidisciplinary care, and develop a Southeastern Wisconsin goals and initiatives. And this has been our biggest initiative this year, is to develop Southeastern Wisconsin goals. Let me change the slide. So our three initiatives that to meet our standard are nutritional education. We developed a 3-part series focusing on breakfast, lunch, dinner, and snacks. Our course is completely online for ease of access. Physical activity is our second initiative, and that is also going to be an online course. We're working on that one right now. Our third initiative was pelvic floor rehab, to develop a pathway to ensure patients and GYN cancers are referred to pelvic floor rehab early and consistently. So you can go ahead and switch. So what's going well? Our nutrition series is near completion. We have completed 2 of our nutritional videos. We are working on our third one. Our dinner snack series should be coming the end of month, September, not August. And so far we're doing very well with that. Physical activity, we're actually taping our video tomorrow, so we're actually doing well with that. We'll see how it goes once we've created that. We found our biggest barrier was access. We did find an Ascension education website that is accessed throughout the country, so that has been good. Pelvic floor rehab, we are able to recognize some gaps where we need to work towards, and our group is really engaged, and the physicians are interested in improving this care. So those are all things that are going well. You can go ahead. Some opportunities. Nutrition is getting the patients to actually sign up for the class. We've had some interest, but with summer and actually having to register for a class, we don't know what exactly our barriers are, but we are working on that. We're going to really promote these classes once the series is completed taping, and then we'll try to really recruit for patients to participate. Um, Physical activity class, we've had some internal barriers. It's been hard for us to move from in person, and then with COVID and not being able to do those things, to moving into an online situation has been difficult for some of our associates to move past. So we're just trying to do the best we can and try to offer some services online to try to bridge that gap. uh, Pelvic floor rehab, like I spoke about at the first slide, was that developing something across Ascension, southeastern Wisconsin, instead of per site, is a barrier, and it's something that we're trying to work towards. You can change slides. Lessons learned. Engaged team members are essential. Finding people that have the same passion is definitely makes the work easier, as we all know, right? It's definitely not pulling hairs out of your head. Being willing to think outside the box. Sometimes I have an idea in my head, and then if I don't think about the way others think of it, or be willing to move past that, then we don't progress. And then keep focused on the goal. So knowing what we want the end result to look like is really trying to keep an eye on that, I think has been valuable. Next slide. Oh, and that's it. Thank you.
Thank you, Chris. And we're
Thanks.
going to hold questions till the end just so everybody can get through their flash talks, but I really appreciate your quick presentation. And then we're going to turn it over to Cancer Center of Western Wisconsin at Westfield. I think Andrea, you were on the line.
Yep, I'm here.
Okay, perfect. Thank you.
All right, so I'm Andrea Larson, and I've got Lisa Johnson-Blesky over out of the camera here, also listening. She's our nurse manager, and I'm our oncology nurse navigator. So just kind of to go through our slides, we are a smaller cancer center, so we are just getting this survivorship program developed from the beginning. So our aim was to offer all new breast cancer patients a survivorship program. We started with just breast cancer to keep our population small so we could start somewhere and grow. So the objectives was each new breast cancer patient would receive a survivorship appointment, care plan, and resources as needed. So next slide. So where are we? 2019 was the year we kind of started this up, and went through some training, some classes on how to problem solve, and got this program developed. 2020 was a strange year. So that was our kind of year that we promoted it, and was kind of difficult. So I feel like 2021 combined with 2020 is kind of the year that we are trying to get this rolled out. So we have a system now for tracking all new breast cancer consults. So that way we can make sure that nobody's missed and we're catching all of our patients. As nurse navigator, that's one of my roles. The RN coordinates the appropriate timing for survivorship appointments. We met with our oncologist, our nurse practitioner who does these visits to figure out what that timing should look like. So I kind of keep track of where the patients are at and making sure to remind the doctors and get them in at that appropriate time frame that we set up for them. And then another thing we are doing is all patients get that survivorship appointment that want it, and then they are given their survivorship care plan, and that also is part of their medical record. So those things are all happening, we're doing that, and that's been going fairly well. And what changes were made? Timing of our survivorship appointments. We had some patients who have longer active treatment plans, the patients who are on Herceptin for a year, the patients who are triple negative, who get neoadjuvant, and they get surgery, then they get more immunotherapy. So those patients have longer active treatment plans, and the timing of when to do their survivorship is a little trickier. So the doctors, nurse practitioner, and I and our team have been kind of trying to follow those patients and figure out good timing of when that appointment should happen. So it's not too late in their treatment plan, but also not too early where they're still in active treatment. What didn't we do yet? We're still kind of rolling all this stuff out that I just talked about. So we need to now address kind of our lack of accessible resources. What kind of resources do we need, and how do we get them to patients in an easy way? So in the next slide. What's going well? I feel like we've had great communication with our two oncologists and nurse practitioner. The doctors, I feel, have done a really good job of offering the patient survivorship and getting them to their appointment. The tracking of our new consults, I feel like we're capturing, I would say, almost all of our patients that are coming in. So I think all those things are going well, and we're getting a good base to our program. What progress has been made? I would guess that about 80% of patients have completed a survivorship visit at the new consults. We have had some decline. We've had some patients who move, who change, health systems. So there's always that population, but for the most part, we're getting those survivorship visits in. Another good thing that is happening is shortly after we rolled this out, our social worker had resigned. So now, just in July, we have hired a new social worker and supportive counselor. So she's just started. So that'll be a really good partner once she gets her feet wet to help grow this program. And hopefully she'll help fill in some of these gaps in the resources. So that's something we're looking forward to. And then barriers. So for over a year, we had no social worker supportive counselor at our site that was dedicated to oncology. And that was a big part of this survivorship, is having that resource. So with that person not being here, that was a big gap that we had. We do have these complex patients that come in that are just out of the norm, that we really need to individualize their survivorship. So just making sure I'm tracking them, following them, and getting them to their survivorship appointment at the correct timing in their plan. And then just having staff help and time to develop and find resources. And just, I'm hoping that today I'll learn something from the other groups that are talking about resources and how people and other teams are getting those out to patients and what types of resources are being used. Just with the last presentation of the online classes was interesting to listen to. So I'm hoping to learn some things about that today. And then some barriers are just patients not wanting survivorship. We are more rural setting, so some patients do travel and don't want to come back for that separate visit, or just don't want it. So that's always going to be a barrier we face in trying to get over that. So. And
Thank you, Andrew.
I think there's one more learning.
Oh, okay.
Yep. And then this is the last slide. It's just our learnings. We learned we definitely have a deficit of resources, and that's something we're going to hopefully tackle over the next year. We learned that all these patients have individual needs, so trying to match the resources that we are going to start working on to what patients need. And then also we've learned that tracking of patients and following them closely and having a dedicated person to do that has been very beneficial. So thank you.
Thank you, Andrea. Sorry for cutting you off for a second.
No, you're fine.
And that's a great question for later for the group. So please feel free to bring that up again later. Okay. And then next we have Gunderson Health System. I'm not sure who is speaking for you. I think I saw a few of you on the line, so feel free to speak up.
This is Taylor.
Okay, thank you, Taylor.
So I'm the Cancer Center coordinator, and then Eileen Williams and Amy are also a part of our team. You can go to the next slide. So our aim was to increase the number of cancer survivors utilizing mental health services. And we're going to do this by measuring the number of NCCN distress screenings completed, and we wanted to implement the use of these screenings across all survivorship visits. You can go to the next slide. So unfortunately, we had to postpone our work on this plan. With COVID, we had many survivorship visits canceled. And so we had to focus on building our survivorship program back up and increasing our visits first. Our breast cancer survivorship continues, that this is the standard to obtain the NCCN distress scale. They've always done this, so hopefully we can pursue this work plan so we can incorporate all our survivorship visits in the future.
Thank you so much, Taylor.
Yes, thank you.
Okay, and then next up we have Marshfield Clinic. And Megan, are you on the line?
Yep, I'm on the line.
Okay, thank you.
You can go to the next slide. So yeah, Megan, I'm the survivorship program coordinator. So we're trying to develop a well-rounded survivorship program in a rural area, and focusing on patient needs from the beginning of diagnosis with high distress screening. Next slide. So far we've come up with a survivorship team, and we are working on getting a baseline of how many referrals are placed. That's being delayed. Actually, I was just messaging with the person today. Our work plan is the nurse practitioners are either seeing or calling a new diagnosis 5 to 7 days after consult. And then I review distress screenings every 2 weeks and disperse those through to the navigator, social worker, nurse practitioners, whoever it may be. And we're averaging about 30 high distress screenings every 2 weeks. And our distress screenings are done at every office visit other than the consult visit. So we have quite a few coming in, and instead of missing them at Survivorship, I think one of the COC standards is to have the distress screenings done. So we just decided to do it every office visit and then monitor it from there to help patients right away. Next slide. So going over the distress screening has been going well. And the nurse practitioners did start seeing and calling patients. And they found that has been helpful to help patients get resources earlier in treatment, some less triage calls and less anxiety that we're seeing in some patients. Next slide. So barriers is we don't have a lot of provider support. They generally don't, we don't get the we're not really able to get referrals placed because they're not really wanting us to do that for some reason. I don't know. Staffing has been a big barrier with staff leaving and work not getting slower. So we've all been kind of plugging in where we can, and then delay on reports. Just getting the time for the IT people to be able to run those reports. Next slide. So overall, we're doing well with seeing patients with the staff that we have. We did get a new navigator, which is helping, and creating data to support getting another navigator as well for our GYN cancers. So actually doing this distress screening and seeing the referrals placed, and I think we did just a small data collection to try to support another navigator, and we had over 60, within 30 days, we had over 60 referrals placed by the 3 main navigators that we have. So that was good to see that we were seeing some referrals placed with seeing those high distress screenings.
Okay, thank you very much, Megan. Okay, and then Dr. Carroll, are you on the line?
I am. I think Amy is going to present.
Oh, okay. Dr. Tavares, are you ready?
I am here. So sorry about that.
Okay,
I
no
just
worries.
glanced down. I'm like managing pages at the same time, but
no worries. Thank you.
So on behalf of the UW and myself and Dr. Sabelle Carroll, who's part of our survivorship program, we'll be discussing what we're working on here at the UW. And this is just part of a slice of kind of what we're working on. But Alexandria, if you could advance the slides. So we do survivorship care planning as part of usually an APP or RN-led visit here at the UW. Our main focus for survivorship care planning has been in these subgroups: breast, colorectal, gynonc, prostate, and now bone marrow or stem cell transplant. We have sort of developed those survivorship care plan templates over time. And so we're engaged in a process of harmonizing them and ensuring that as we move forward with other disease types beyond this, that we have sort of a cohesive, standardized package for survivorship care plans, as well as the transition visit, which is what we call our survivorship care plan visit. Much of our research is focused on leveraging health information technology or the EHR and patient portal tools to do this work. Alexandria, I'll take the next slide. Thanks. So for this sort of particular project that we're currently presenting to you guys, we've been working on developing a generic unified. So we want unified templates that basically all follow the same format and the same design, that incorporate lots of EHR-based tools for automatically importing the information that we need so we can decrease the amount of time that we're spending creating these, as well as to drive structured data capture so that we can pull this out on the back end after a year, 2, 3, 4, et cetera, to help monitor where we are and what we're doing. We also haven't created a generic template to satisfy the needs of those disease types that do not currently have survivorship care planning. So those have been sort of our dual goals. I'll take, yep. So we are using the EHR to create our survivorship care plans. We actually store it under the problem list. So it's a little bit fuzzy, but this is a snapshot of, say, a breast cancer problem on our problem list within Epic. And then there's a pre-built section that's labeled oncology treatment summary. I think most of you will agree it's a little bit confusing that it's labeled oncology treatment summary, but that's the standard language that came out from Epic, and we have not gone to the trouble of renaming it. We use this section, this functionality of oncology treatment summary, to create our standardized EHR leverage survivorship care plans. And you see a screenshot here of an example of a bone marrow transplant survivorship care plan. What I'll emphasize to you guys is that a lot of the language that's showing up here, and there's pages for transplant, is all sort of automatically pulled in, so that there's very little effort on the part of the RN navigator doing at least the preparation. There's quite a bit of work as they have to sort of navigate through some pieces for transplant about what care is due when. This particular method automatically captures the end of treatment date. It captures for us that the survivorship care plans are done, and it also captures who they were delivered to, as well as delivering it to the patient's MyChart account for access there, in addition to the paper copy. So what have we done? So we track a host of metrics. We track eligible patients who receive a survivorship care plan. We have our Healthy Planet cancer registry turned on to help us track what our denominator is. We have an oncology specific closed visit validation process that forces our hematology and oncology departments to have a malignant diagnosis on the chart for any patient who is seen, as well as to have staged that. So we're able to parse out who is a cancer patient with us and what their stage is. We're able to track which of those potentially eligible patients then have gotten a survivorship care plan based on disease type, which percentage have a primary care provider, an oncologist who's been sent a survivorship care plan, the percentage who've received a survivorship care planning or a transition visit, because we have templates that capture whether those transition visits have occurred. And then we're able to track using flow sheets that the RNs or APPs document in during the transition visit, what activities and referrals result from that. We're in the process of updating the survivorship care planning or transition visit questionnaire so that it can be utilized more broadly. It was a little too specific. So it's being made, quote, generic in the sense that it will work regardless of disease type. I believe if you advance, Alexandria, we have some screenshots of it. So this is a sample of our cancer survivorship program questionnaire. On the left-hand side, it asks a series of questions about concerns. And then the concern is paired with a request, because what we realized quite early on is that survivors would report a concern, but they didn't necessarily have a request for referrals or information, either because they'd already received that, or because they felt like they just weren't ready to get it, or they weren't in a place where they could take advantage of it. And Alexandria, if you advance once more, this is the transition visit flow sheet that is paired to this questionnaire that lets our survivorship care program clinicians very rapidly sort of capture this data. So they the patient receives the questionnaire in advance. They provide it to the person doing the visit. There's some discussion just because sometimes patients aren't sure what the questions mean, or they're not sure if they should report something. So it's a little bit, the result that we capture is a little bit filtered through the clinician. Alexandria, you want to advance one more? So what has been going well? We're regularly meeting with our clinicians who are providing survivorship care. We're learning from their experience. We have over 5 years worth of data that we're sort of plowing through, at least in breast, and we're making these changes to improve the workflow. We've been lucky to have a lot of grant opportunities that have allowed us to advance the IT build. We have an AYA program funding that we're using to really sort of advance what we're doing there. And we've been able to partner quite broadly across the institution. We've now included an IT analyst in our survivorship program budget, and we are heavily engaged at the UW now that we're not quite as focused on the pandemic, and some specialty care redesign that's going to allow us to add more navigators and survivorship coordinators to help tackle all of our disease groups. We struggle profoundly with how messy it is to manage survivorship care at a large academic medical center. I suspect that many of you have similar problems, but we have multiple departments that are operating on these patients: urology, ear, nose, and throat, ortho, in addition to our surgical oncologists, and they don't all talk to each other. We have then hematologists, medical oncologists, transplanters, and then radiation oncologists. Somehow we left them off this slide. Some of our patients may come in through surgery, go to medical oncology, and then radiation oncology. Some may come in at hematology, never see anyone else. So it's just very messy for us. And we have a lot of unique populations, such as our peds crossing over into adult world, our adolescent and young adults. And we have multiple clinic sites and locations spread out over, a 2 or 3 hour radius. And that has proved to be complicating for us. We are trying to drive it all forward by sort of hooking it all into our instance of the EHR.
Thank you, Dr. Tavarik. Okay, so thank you everybody for your quick flash talks. I really appreciate everybody just sharing what they've been experiencing. And so now we can really have an open forum for discussion. So I'm just going to end the slideshow. And again, this is really your time. And so you can ask about something that somebody's doing at their system, or you can ask just something about how they're handling a certain survivorship referral or things like that. So does anyone have any burning questions they want to start with?
I don't have any questions, but I do have a link for Andrea, what we use for survivorship, and some booklets, so I can put that into the chat. It's a nice booklet that, because breast cancer is pretty much all that I have been doing right now, since I've been getting pulled in every other direction. So this booklet, even if they don't finish treatment and they're on Herceptin, it's a nice booklet that I give them before the care plan can be completed, so then they have the resources. And it's also got like the treatment handbook for support, breast cancer for the support partner, sexuality after cancer treatment. So there's different books on there as well. So this is what we switched to instead of a generic survivorship booklet.
Thank you, Megan, so much for sharing that. And then if anybody does have any booklets they want to share how they're doing it at their system, please feel free to put that in the chat as well. And then does anybody want to discuss, so I know Andrea brought up about the resources they're using and how they're getting it to people. Does anyone want to discuss any resources they've found valuable or not found valuable?
This is Amy Tavarik. I wanted to ask how people are managing some of those resources in the face of the pandemic. So we had been in the process in February of 2020 of creating a 6-week class that was going to cover a variety of topics that we had discovered were of very high value from sort of extracting our data. So I'm sure it's a shock to everybody online that nutrition and physical activity, and then this fear of recurrence and some of the psychosocial implications of having a cancer diagnosis were very hot topics. And we didn't feel that, necessarily these needed referrals for everyone, right? Our survivors were telling us that a referral to, say, a nutritionist or a physical therapist wasn't necessarily what they wanted. And so we were in the process of creating a series of classes that were going to span over about 6 weeks. And we'd planned to do many of those in person. And of course, all of that work got shut down. We're turning around and reimagining what those might look like. But I guess as we're doing that, I'm wondering what others are doing and how they're managing that right now. And I've killed the conversation.
This is a service center, so that was one thing that we struggled with as well, and that's why we decided to try our online classes. So we're lucky enough in our system to have a I don't know his title exactly, video auditor, and he's assisted us with videotaping and getting our classes online, but they look great, and so far we just have to get people to kind of classes and get barrier of having online access. I think is the biggest problem, but it has resolved our in-person problem.
Sorry, Chris. I'm not sure if everybody was able to hear you or not. It sounded a little robotic to me.
Yes, it sounded like there was a lot of really great information, and I just really want to hear what Chris said. But it was like Darth Vader underwater.
Yes.
So it's probably the mask.
So I heard that you had switched to online classes, and then our particular concern about online has been that we know that there's probably about a 25 to 30% segment of our population who's just not either comfortable or able to take advantage of online. And so it makes us nervous that we're broadening disparities. And I think you started to say something about that, Chris.
That was one of our barriers, of course, is people accessing that. One of the things that we've talked about is being able to access it while they're in the clinics. For instance, like when they're getting their treatments, is that we have the ability to allow them to access those classes while they're sitting there, so they can watch our classes during those times.
So sort of using the clinic location and the clinic services. Yeah. I like that idea. Has anyone tried using like mobile devices that you share with survivors for that like a few week period? Because we've also toyed with that idea, but there's a lot of concerns about how we send them out, how we bring them back in, how we clean them. What do we do if someone fails to return them? I gather no one's tried it.
We have not in Marshfield.
Megan, have you guys been doing online classes as well?
No, we had, we sadly only had 2 support groups, and it was for breast cancer patients and prostate patients. And none of them really could grasp the Zoom meetings, Link meeting, whatever it may be. They had a hard time navigating those. The prostate, it was kind of a group, well, they just talked about their ED the whole time, and that was all.
It was a support group for ED.
Yeah, and it was pretty much just.
Hey, that's probably good, right?
I mean, it was really just one person talking about it the whole time. So those meetings never really went anywhere. But for our breast cancer patients, and it was gynonc as well that we did add into that group, there was about 10, 12 ladies that would come or join, and then they had me do a survivorship talk and only one person showed up. Or online, and it's like, and that's how the meetings were follow up to that as well. So it's kind of hard to get a provider to donate their time to do a support group if you don't know if anybody is going to show up. So all of our support groups right now are kind of, well, they're not up and going, other than our Stevens Point location does have some. So we do have somewhere to send people, but I'm not even sure how well that one has been working. So it just, online stuff just isn't working for the rural area. Most people may not even have great internet service, or may not have it at all, may not have a smartphone. So,
And if even if they do have those things, I think what we've noticed is, you know, the digital literacy, if you just haven't had a lot of exposure to it, if you haven't had someone show you how to do it, just the discomfort potentially with doing it has also been a barrier.
Sitting in front of a screen again. I mean, some people may watch the news all day or
Right.
look on the computer or whatever all day,
Yep.
and then have to have a meeting on a computer again.
Yeah, no, we hear you. So some mixed success.
Does anybody else have anything to add to that, or any of their experiences they want to talk about?
Um, and over here in Richmond, so we hadn't had a support group in person since COVID. We had 2 per month that we were offering patients before, and just general support groups. They weren't for survivorship or for any specific diagnosis. So we're trying to now redevelop support groups and kind of start over and figure out how do we get that resource out there to patients. Even if it's not survivorship specific, just getting the support groups back in action, and how that would look with COVID still hanging on, and if anyone has had any successes or failures with support groups during this time, that would be helpful too. So we're kind of in a support group resource rut right now, I feel like. So
We are not planning to do any of the support groups online right now. We have a event that we're doing in October for breast cancer patients. Even our first virtual event that we did this year didn't go over very well. So it's a hit and miss with trying to get things back going, especially when we're not able to meet in person.
And I have to say, you know, our initial impulse was that we were going to kind of sit tight and not try and get anything up off the ground until the pandemic was over. And what we've sort of realized is that, you know, this may be our opportunity to at least try and build out some of the virtual online portions of it. You know, we've been doing telemedicine visits for some of the survivorship care planning. You know, there are areas and populations that we feel we can't serve well that way. So we're going to have to figure out what we do there. But I think in the meantime, we're going to kind of push forward with some of the virtual options as a way to at least continue to reach out to folks and offer them some of the benefits, even if, you know, we feel we can't offer everything the way we'd wish to. So it's really great to hear what experiences folks have been having, because it does affirm my fears, but
Thank you, Dr. Tavares, for sharing. And then Sherry just said in the chat that they switched their support groups to virtual with fairly good attendance. Participants have asked to continue the option when they do return in person. So it seems like there's just quite a variety across the state.
Sherry, could you remind me where you're located?
We're Ascension in Milwaukee.
So like us, a more urban environment, potentially with better penetration.
Yeah.
And then folks are happy to do it because do you think you actually have better attendance that way?
I think the one group has stayed consistent because they really like the group. And the other one, I'm not sure because there's some people that still refuse to attend virtually. So it's really a mix, there's the people that love, to participate virtually and there's some that just miss that human, face-to-face experience.
Thank you, Sherry. And then I'm just curious for my own knowledge, has anybody utilized referring patients to Gilda's Club? They're located in Madison, but they've done a lot of Zoom support groups that have had a little more increased reach across the state.
I would say that for us, our social workers refer patients to online support groups and other resources like that. We're not tracking whether they attend or utilize that resource in a formal way, but I know that the social workers often will have a list of resources for our patients.
Okay, thank you. And then I'm also wondering, has anybody been experiencing survivors expressing any specific concerns with regard to COVID, vaccine, booster shots, anything like that? I know that's a whole other big topic, but I was wondering about that.
I haven't noticed patients in survivorship. I mean, it hasn't been a topic that's been brought up often, so. Mm-mm. And I have another question on a different topic, unless anyone had anything else left to share on that one. But one thing we kind of relooked at this year is with complicated patients or patients who are on active long treatment plans, like with other sites, when do you guys time your survivorship visits? Like, the patients who we get in easily are the patients who come in, they get radiation, go to AI, we can figure out, okay, after radiation, we get you under AI at your 4-week checkup, let's have you do survivorship. I mean, they're kind of straightforward, but we get, these patients who are on long chemos, it's like, we're still kind of struggling with trying to find the best time of when to get that survivorship visit. And I, heard Marshfield say they're doing early visits, like 5 to 7 days to introduce, the high distress things. But we're just trying to figure out, I always have this group of patients who I feel like are just hanging out forever trying to get the right timing. So we've definitely struggled with that. We're trying to right now mainstream that every patient after active treatment is done to get in with survivorship. But again, that can look very different for patients. So I didn't know if any sites had any input on what they're doing there either.
I would say that's a continued struggle for everyone. I would echo your pain points there. Our triple negative breast cancer patients who get adjuvant capecitabine and adjuvant pembrolizumab, it's hard to know when. It seems like therapy goes on for 2+ years for those women.
Right.
We have the best luck when they move through radiation, because radiation, as you may have noted, has this very highly structured 4-week post radiation check-in, which we hijacked for survivorship care planning for our curative intent patients, and that works great. It's everybody else that we struggle with, and we have a complicated network of sort of overlapping referrals, and we're hoping with navigators and survivorship coordinators we'll catch more of those patients who are falling through those cracks. But I'm interested in, Dina said that they're having some good luck timing it. Is that also through radiation? Because I see breast, prostate, and gyne and head, neck, and I wonder if that's radiation. I'm wondering how people are tracking this.
So for breast cancer patients, for us, I mean, when they go through radiation, it's pretty clear when you're going to get it. If they're gonna be on a year of Herceptin, that's when I'll still give them that booklet, the survivorship booklet, because it's a lot of good information about long-term side effects and just survivorship information. And then I'll talk to them about their care plan, but I don't give them their actual, I mean, I could work up the care plan of up to where where we just have to add the last date of Herceptin. And then when they're done with Herceptin, I will give them an updated care plan with all the information and then upload it into into our CMR. That's what I do. Sometimes they want their care plan right away and it's pretty much finished and I can just guess looking at our orders, when they're going to be done. But then I do meet with them before they're completely done. For the people that are on capecitabine, I give them the handbook and then kind of just follow along with them throughout as well. But I try to give those within the 4 to 6 weeks of starting. So between their first and second maintenance to give them their care plan. I used to do more survivorship care plans for prostate and gynonc and head and neck, but with COVID and working in the chemo clinic and doing other navigation roles and triage, those kind of been put to the side. But for those, it's usually when especially head and neck, I don't do a head and neck until they have a scan that is cleared, because you never know when they're going to recur. Gynonc is usually when they meet up with the gynonc doc after surgery, and prostate is with their follow-up as well. So I don't know, those are usually about 6 to 8 weeks after surgery.
This is Deanna Burling. So we do things similarly, as Megan had said, with I work in radiation oncology, so that is, that structure definitely helps to provide these treatment summaries. But for our patients that don't go through radiation, our navigators are excellent at creating the plans and communicating with our team to make sure that everything is accurate in the plan. And for patients that are not done with their, adjuvant endocrine therapy or their, Perjeta, Herceptin, we do give a plan still, and then it is updated some of the time. I would have to say I'm not 100% because I'm not always, involved. It's mostly the navigator that is doing that. And as far as like head and neck and GYN, head and neck, we wait until after their first PET scan, much as Megan was saying, to make sure they don't require any additional therapies. And for the GYN, we do like to structure it kind of at the 1 month to 6 week mark, because they do need like the vaginal dilators and the pelvic floor therapy. So that's kind of what our routine is currently.
I also saw that Taylor from Gunderson put something in the chat that they shoot for 3 to 6 months on average post-active treatment. If they're on prolonged chemo, it's up to the provider. Sometimes they still like to stick with a 3 to 6 month window. Taylor, do you want to add anything more?
That's basically it. Sometimes I know like our prostate patients, if they're like radiation only, it'll just get bunched in with like a radiation follow-up, like the 1 or 2 month radiation follow-up. It just kind of depends on the treatment they have and the department that they're in. But on average, we like to shoot for 3 to 6 months.
Okay, thank you. And I apologize if I'm missing anybody's comments. Please let me know. I'm not trying to cut off anybody or ignore any comments that you're sharing, and feel free to participate in multiple ways.
Does anyone have like a good automated referral process? I hear a lot of navigator support, which, frankly, always makes me very jealous because I feel like we don't have enough navigators, although maybe that's just the common perception. There's never enough navigator to go around. But does anyone feel like they have a really robust automated referral system, or is it largely relying on the navigators to trigger this?
Are you asking for a robust auto referral for new
In other words,
diagnoses?
No, for referral, making sure that we're capturing. So one of the things that I think is painful for us is we know who's supposed to get it, but making sure that we kind of hook up the patient at the right time. And we've been able to kind of check the box of it got offered, but for whatever reason, the patient didn't want to do it, or it was deemed inappropriate, right? Like that sort of thoroughness of that automated process of making sure. And I haven't come up with a good way. And I see Dina posting that navigators are essential. And that's sort of becoming our feeling as well, that we're just never going to get much above our 50% until we have more navigators on board.
Yeah, we have disease-specific navigators, so they're each responsible for their own, I guess, population of patients. And so they are responsible for initiating the care plan development. And then if they see an advanced practice, like Deanna, then she helps provide that visit and that care plan. If they don't see an advanced practice provider, then the navigator is responsible for providing the patient with the care plan and reviewing it with them. They won't get that comprehensive visit. Not all our patients do unless they see the NP, but at least they're getting the care plan and any like educational materials that they might request.
I would have to say that our navigators are also very helpful in queuing our providers on things that are, support services and referrals to rehab and things like that. So if there isn't a comprehensive visit by an APP, then our navigators really kind of know that disease state and know what needs to be done. So they're kind of a stopgap in that regard too.
Does anybody else have anything more to add to that, either in the chat or you can unmute?
Our referral, we do have a referral option. We tried, it was almost 2 years ago. We're going department to department to figure out how they would be able to get the referrals into survivorship. And we started with dermatology, and they were sending over basal cells, squamous cells, like sending over a lot of people that didn't really need care plans, and the patients didn't really care to have them. But they were pretty good about putting the referral, and then they just stopped. Rely on our chemo nurses to let us know when patients are done if they didn't see a navigator, which those slip through the crack as well. So it's pretty much a manual process, watching who is going to be ready. The breast navigator is great. She lets me know because that's all she works with. But I mean, our solid tumor navigator works with all solid tumors. And then our transplant, we do get, those navigators let me know when to do those care plans as well. But overall, it's just a manual process of tracking them through their whole treatment and then figuring out when to see them.
And Megan, can you remind me, are you used an Excel spreadsheet to do that for tracking, and that's mainly reliant on you doing that for every patient?
Yes, yeah.
Okay.
I get all positive paths every Monday for our clinic, and then I go through that and then I add them to my spreadsheet, which is just a disaster because I haven't really been working on them when it's just the breast cancer patients this year. So it kind of sucks knowing that those patients aren't getting the same care, but can only do so much.
Does anybody have anything else to add to that or another question for the group? I guess in the meantime, I have a question. I think Andrea's presentation reminded me of this. How are different health systems getting patients interested in cancer survivorship care or feeling like it's something that they want to get information on or pursue? Because I definitely know a lot of people aren't interested in that.
So at our site out here in New Richmond, as a navigator, I do all of our chemotherapy class education. And so right now our program's small. We're just breast cancer focused for survivorship. We hope to grow once we get things ironed out in this program more robust. But when I do my chemotherapy class, I will talk to the patients. We have a little rat card flyer. It's just very small that just says survivorship. It talks briefly about what it is. We do have a brand new webpage that's very simple, very basic, that just they can click on to get a few resources online, but also just explains our program. So I point that out at chemo class and give them the little flyer in their chemo booklet, just so they're aware that that's going to happen down the road, after their chemo. So that's, as a navigator, where I make my plug for survivorship. We do depend on our physicians, our two oncologists, when they see new breast cancer patients that aren't necessarily going to get chemotherapy, so they won't be in that chemo class. They then will discuss survivorship with them, the timing of it, and then they'll put that in their after visit summary so I can arrange the visit with the patient and the nurse practitioner. So it's partly relied on the navigator to introduce it, and the other part of it, we really rely on our two physicians to talk about it and introduce it to the patients too. So, but again, we're small, so we're able to do that pretty easily. As we grow and as we offer it to other diseases and we get our program going, we'll have to reevaluate how we're doing that. But for now, it works with some glitches. So.
Thank you. And I saw Chris added in the chat, we developed a newsletter that we're distributing monthly. We're having content experts writing articles each month that affect survivors. So thank you, Chris.
Actually, I have a question for Chris then based on the newsletter. Are you seeing folks reach out to you asking for the survivorship care plans or care planning visits based on those newsletters?
We just started the newsletter last month. So it's really relatively new. We're working on distribution in a safe, effective manner with COVID. So we have a QR code and we just got permission to be able to put it in our waiting rooms as long as we dispose of any copies that are touched and not taken. So we're really on these stages on that, and we haven't started in person distribution yet. I'll type it again.
Yeah, sorry, Chris. I apologize. It's the Darth Vader underwater again. So I'm sorry. Thank you for putting everything in the chat, though. I appreciate it.
When we do our survivorship, we kind of just present it as part of their care. I mean, we are smaller, so it's easier for us in the ones that we can reach out to. So I'm the only one that does care plans, so I can't charge. So they're okay with coming to meet or getting the information because it's not getting charged. And maybe they'll say, no, I don't really need a care plan, but we still assess them to see what their other needs are. So maybe they're not getting the documentation survivorship care plan, but they're getting assessed at the end of treatment when we're able to get to them.
Okay, and then we'll just let Chris have a little time to put what she was saying before in the chat. And she just said that the newsletter is new last month. We are working on safe distribution with COVID. We have a QR code that they can scan. They just received permission to distribute in person as long as they dispose of them once they touch. So we are not sure how it'll affect yet, question mark. Thank you, Chris. And then any other questions or concerns people want to bring up for the group? And I apologize, I know that the virtual meeting isn't the best environment for this, so I apologize, but I hope you guys are still feeling like you can ask your questions.
I don't know. I always feel like, virtual has its challenges, but hey, I didn't have to drive anywhere today, right? So.
And Sherry did add that they can subscribe to the newsletter via the QR code. So from the Wisconsin Cancer Collaborative side of things, are there any resources or gap areas that you feel that we have that maybe we could create a resource or a compilation of resources that would be helpful to anyone?
I'll, I don't want to overtalk. Alexandra, I would say, one of the issues, right, can be that people get served pretty broadly over the state, right? So Marshfield Clinic, probably, you guys cover a huge territory up north. We are certainly drawing patients in from 2, 3, 4 hours away. We have patients traveling from the UP, and it can be challenging sometimes to know what resources are available locally. It's usually fairly clear to us what's available in our area, but I think we struggle with knowing how can we serve patients who are coming from some distance. And I imagine that if there was something that this group created across the state, right, it would potentially help all of us. But that's just my top thought when you ask that question. But maybe I'm off base. I'm interested in what others think about that.
Thank you. Yeah, it's just helpful to hear what resources maybe people are finding they need. No promises or anything, but it's just good to know and good for us to evaluate how we can better serve our members and the people we're working with.
Well, especially as some of the options will remain virtual, right? If there's a resource that Milwaukee or the UW or Gunderson or Marshfield has and it's virtual, that does then become available to everyone across the state. And frankly, I mean, I know our pro healthcare team has great classes that we didn't offer for a long time here.
Yeah, thank you. And I think Deanna said it'd be nice to have general unbranded, well-researched information to provide to patients, focusing on integrating some Wisconsin health challenges into the resources. And I will add, I think it'd be helpful for everybody again to share like the web pages or the resources that they're using, just so we can kind of cross-reference and see what is useful to people and what's not useful to people. I have found it really interesting and fascinating to seeing how everybody is approaching these resources and their survivorship links on their web pages and booklets that they're providing to people. I will also add, we are doing a compilation of resources for survivorship more broadly that we've had on our webpage. And so if you ever have any additions you want to share to that, please feel free to let me know. I can share that in the chat. I think you all have seen that before. I've sent that out a couple times, but I'll send it in the chat just one more time. And then any other questions, concerns, barriers you've been facing that you just want to talk about, successes? I'm all for all of it. So if there's anything you want to share or something you're really proud of, please feel free to share with the group. Okay, maybe that was a conversation killer. Sorry. Anybody else have anything they want to add?
Looks like Sherry's asking in the chats about the continuity of this. I have to say, for me, it's been so helpful to hear what folks are doing and to just get a sense of what's working across the state as we continue to work on developing our program.
So that's a great question. So with this survivorship community of practice, so we're continuing till December, and that's when we reevaluate just progress in your work plan, different metrics, things like that. I guess, would everybody find it valuable to have another meeting in the future once we've worked on our work plans? Maybe not December, just because it's so busy,
Yeah.
but maybe
I was
January.
thinking that it would be really helpful to have some sort of continued working group through this. You know, maybe after December, do we define what those objectives would be for that group? What has been valuable and how do we continue? Maybe it's not necessarily working on a project or something, but maybe collectively doing something together. I don't know. But I like the idea of the collaborating, since we're all, probably one of our biggest barriers is staff and resources, but it helps to hear what other people are doing or how they've been able to overcome that. Or maybe it helps us to get started with something that, because we have limited resources, it gives us a starting point.
Great, I'm glad to hear that, Sherry. Anybody else have anything to add on that?
Yeah, I think that would be helpful too, to just periodically check in. Again, us being a newer site to this, any information we can learn and gather from what other more established sites are doing is always helpful. And I think that, you know, even into next year, 2022, as COVID changes things, that obviously it's made a huge impact in the past, but what will things look like in the future? What are other sites doing? I think just to continue the communication would be really helpful.
And I know that there were other sites that were interested in this community of practice originally and had to drop out because of COVID. So we had 40 sites who participated in the original survey, and a lot of them did have to drop out, unfortunately. So I know there's been some interest and talk about maybe joining later on from them as well, which might create a more, you guys are a great group, but also just adding more robust number of health systems into the conversation. I know it's been really interesting to me to learn from everybody what they're doing. And I hope that you can feel like anybody in this group you can reach out to. And that's why I sent out that one pager of all the contact information. So I want you to talk to one another and feel free to ask each other questions. Or if you're working on a similar strategy, it can be helpful just so you're not feeling like you're reinventing the wheel. And so I will follow up with that one pager again and some resources just after this call with the recording. But just please feel free to always reach out to people. And then just for my own personal knowledge, have you all found the flash talks to be helpful in kind of setting the stage in the work you're doing, or have they not been helpful?
I think it's great to see what other people are doing, right? It's one thing to hear it, but to sort of have some examples and to just, especially when you're doing something like a virtual meeting, the audio and the visual reinforcement is great for me.
And I saw Sherry said yes, and Chris said yes, I enjoyed the presentations. Okay, great. Okay, so generally positive feedback. If you have negative feedback too, feel free to let me know because I want this to be useful to all of you. Okay. And then I did want to add that I've been working on, I talked about this, I think, in our October meeting as well, just trying to compile a resource of Wisconsin specific studies or Wisconsin specific survivorship projects that have been worked on, things like that. I know Gunderson had sent 2 articles. I think UW had sent a few articles. So if anybody has anything, doesn't have to be a scholarly article either. It could be a report or just something you want to share. I think it'd be helpful to have some Wisconsin specific examples or resources just to share with the group. Okay. Any final comments, concerns, questions?
I guess, is there something that anyone else really wants to explore? I mean, I personally always have interest in the referral processes and how people are tracking things out back and making them less manual. Because of the size of our cancer center, right? Like manual just doesn't work. We just don't have enough person power to do it manually. And so if anyone has like what they think is a great automated workflow or a great way of tracking this or pulling the data out, I would love to see it.
I would as well. Right now, our cancer center has 6 sites and we're just doing this at 1 site. So again, the manpower at 6 sites to track all those patients, if there's a way to do it together once we get it out to other sites, that's going to be a game changer is how we track patients. So that would be very helpful information to have.
I think there's always going to be some manual process. So like right now we have a report ran for the distress screenings. And then I put on a filter and then I get rid of all of them that the distress screenings are less than 5. So 5 and above I keep, and then I have to go through each patient and figure out what they need, or I figure out what their diagnosis is so then I can send it to the right person. So at least looking there if it's something that I can help with, if they're in survivorship. So kind of looking at that as well. But there still is a manual process of after the report is ran that I am noticing.
I don't think any of us really imagine we can take the human end user out. It's just a question of how much human end user power do we need?
It's not too bad. I mean, with running the reports every 2 weeks, it's a pretty small number. We ran this report at the end of the year last year, and for the distress screenings, and then we also did referrals, and it was a lot of numbers to go through. So this year, I got back from maternity a couple months ago, so now we're trying to get back onto the right path. So I'm just waiting for that referral document to come through so I can look at that. But yeah, normally I'd like it every 2 weeks, so then it's not a whole. I do it at the beginning of the week and then it's done with, and it's maybe 30 to 50 people that I'm looking at instead of thousands.
And I think Ascension too, I think one of your strategies you were working on improving referrals and you were doing some sort of Epic build or switch to Epic, was that correct? Yeah, and Sherry just added to the chat, we built in a distress screening survey in Epic that can be sent to patients via MyChart and auto-populates into the flow sheet. Okay, Thank you. Okay. Well, I really appreciate everybody's time today, and thank you for the questions and just sharing the progress that you've made and the barriers that you've been facing. I really appreciate it. And again, everybody, it was just wonderful to hear from everybody, and I really value the work that all of you are doing. I know you're balancing a lot with being pulled in a million directions, so I really appreciate it. And then I just wanted to highlight a few resources. So the National Association of Chronic Disease Directors does have a resource that I just wanted to put into the chat. And they have several different resources for providers and for patients. And so that has been a really great resource. There's also some continuing education credits, things like that. There are some avatars that can help speak to patients or walk through different situations. So like things like emotional distress or diet, things like that. So I did want to share that resource with you all. And then again, if anybody has any resources they want to share or that they have found valuable, please always feel free to reach out to me. And then just as a reminder, so we are continuing to work on the work plans. I plan on checking in with you each in December. And then it sounds like there's some general interest in maybe a January meeting after the holidays. So I will just put a note for that. And I'm glad that you all want to continue talking to one another. So thank you for that. And then any final comments? Okay. Well, thank you. And please always feel free to send anything that you're proud of. We do sometimes feature people in our local newsletters. So it's the Wisconsin Cancer Collaborative newsletters. So just feel free to reach out if there's anything you're really proud of. Well, thank you, everybody. And I hope you have a good rest of your day. Thank you.
Have a good day.
Thank you.
No.